And it's my pleasure to introduce our next presenter. This is Dr. Carol Hill from the Alzheimer's Association. And he will present the topic Alzheimer's Association priorities in the area of disparity research. You're very welcome, Dr. Carl Hill.
Okay, thanks, Julia. I changed it up just, and just want to talk a little bit about pursuing health equity in Alzheimer's and all other dementia. Have enjoyed listening to the presentations, and it's after lunch, so we've got to get a little active here, because we had a great lunch, and hello to everyone that's participating online. So, just how do I advance? Okay, all right, thank you. Yeah, so just a reminder of who we are, and really excited about co-sponsoring this important workshop series with NIA and Duke, but the Alzheimer's Association is a global organization at the intersection of care, support, and research. And I think that is really important for a lot of the discussion that we've had around disparities here, because we have the chance to take findings and go into the community and do something with people to reduce risk, giving people education and awareness. So with over 70 chapters around the country, I think we are uniquely poised from that perspective. No other organization has that footprint in communities around the country. So, this talk will focus on, disparities research and what we think, but also what we can do to address these in underrepresented and disproportionately affected populations. I don't have to remind anyone here, but I think it's an important point that came up this morning from Dr. Saba at the Barrow Neurological Institute in defining Alzheimer's disease, which has to include amyloid, but there are other types of dementia that could be relevant for populations that are disproportionately affected, right? And so we've talked at length. Tim talked about dementia being the second most common. And given Igor's talk yesterday, I think in thinking about inclusive perspectives for risk, it is important for us to think about the different types of different types of dementia when thinking about those populations that are most at risk. High level, more than 6 million Americans are living with Alzheimer's. COVID has not been kind for individuals that are suffering from Alzheimer's, a 16% increase in deaths. And we'll talk a little bit about a special report that I think was critical in this discussion. Still giving some background on the Alzheimer's Association, we advocate, so a lot of discussion has been around structural factors. When I hear structure, I hear policy change or resources that allow for policy change. So in 2021, there was $3.1 billion allocated for Alzheimer's research at NIH, and that's up from $448 million in 2011. Much of that was momentum created by the Alzheimer's Impact Movement. That's a part of the association. So some real good, I think, intervention at a structural level from the association. What does that funding do? Well, it does this kind of thing. It creates all of these Alzheimer's disease research centers. There's one here at Duke. There's one that Dr. David Bennett is the PI of it at Rush, and there are many others around the country. More research centers means more robust research for sure, but training early career investigators, and then certainly taking into account some of the geographical sociocultural factors that are local that could be important for understanding risk for specific populations. We talked about it earlier today with Dr. Saba, but there's been much discussion around aducanumab, received approval from FDA. CMS is considering its position and whether it will be covered. that's been all over the news. We had great discussion around that. But also, I think, which was, received a lot of attention last year, was the Alzheimer's Association's special report on race, ethnicity, and Alzheimer's in America. So this is the first nationally representative sample report that I've seen that had a really nice representation of Asian, Black, Hispanic, Native, and white Americans. And we had a chance to study differences around knowledge and understanding of the disease, access to care and support, interest in clinical trials. So I'll get into some of that data later, but I think this is as impactful as aducanumab's approval of FDA. Maybe not, but we from a disparities perspective, it was quite interesting. I'll get into that data later, but it's all because there are disparities, as we have said time and time again here in this meeting. Older Black and Hispanic Americans are more likely to have Alzheimer's. I think about these factors as determinants and those that could be fundamental, right, for all people, right? You're thinking of disparities. I thought Igor had a really good presentation yesterday where he showed some modeling that showed that hypertension was the cause for the disparities. But there are just so many factors that we have discussed over the last 2 days. In my mind, some are fundamental for all people. Everyone should have access to them. And then there are some determinants that people experience along their life course that are unique and can present risk for certain populations and communities that we have to really double down on and understand. And that was, that came out in Dr. Keith Whitfield's presentation, the last presentation yesterday, in this discussion of comparing versus really digging deep into the unique experiences of certain populations. So one fundamental, I would champion, at least two fundamental factors. And so one would be being able to receive quality healthcare, right, in a timely manner, right? So being able to get a proper diagnosis is fundamental for all people. To know when to get a diagnosis is critical and so important. So let's stay with that. I think we would all agree that that's a fundamental factor for understanding health disparities. So we'll put a pin there. But when thinking about the determinants for health disparities in the dementia research, has a bit of a cheat sheet with the Lancet Commission identifying quite a few in their assertion that 35% of global dementia may be preventable. They identified education, early in life, hearing loss, hypertension, obesity, many of these that surround Tim's presentation in terms of cardio metabolic risk, and added 3 additional in 2020: air pollution, where people live, a traumatic brain injury. I think of that as an occupational risk for some people, and when they endure a TBI. We talked about that a little bit yesterday, Mackenzie. And then excessive alcohol use. I think about the ways that people are coping with in the pandemic, being isolated from their caregivers and turning maybe to excessive alcohol use to cope. So all of this has a context, but it provides a bit, I think, of a cheat sheet for disparities researchers who are thinking about identifying, like Igor, those factors that are important for the disparities and how we could, most importantly, from a public health perspective, intervene, right? And so we talked a little bit, Brian talked about genetics and Alzheimer's, our first talk yesterday. There's growing research that's showing that the genetic, the known ApoE4 gene, or E3, as David told me yesterday, but when thinking about disparities, it's less likely to be attributed to genetic factors and more likely to think of other determinants that are important for some of these disparities that we see. It's Happy Social Work Month. Did everyone know that for social workers? No? Okay, well, so social work is important. It stems from sociology. And when I think about some of these population level or community level differences, I think about my intro to sociology course at Morehouse College, HBCU in Atlanta. And we talked about Max Weber, who was a German philosopher who had really honed in on traditions and values and the ways that people live, the decisions that they make as a way for understanding their many outcomes. Years of life expectancy could be one of those, but really thinking about a lifestyle, if you will, right? And so we know in this case, the Sprint Mind study in 2019 found that getting blood pressure under control, so in the intervention here, getting that systolic number to 120 led to a 19% reduction in mild cognitive impairment, 17% reduced risk for dementia, and a 15% reduction in both MCI and dementia. So, you think about blood pressure, it's diet, physical activity, doing the things that manage a lifestyle, really important. The Alzheimer's Association is leading the US pointer trial right now. We're recruiting and collecting data from participants, which will, studying the recipe of physical activity, how much, what kind, nutrition, whether the Mediterranean diet will improve cardiovascular health, and then cognitive stimulation and health coaching for support. But really, randomizing people into two groups. One group gets the intervention to see the impact of this kind of lifestyle modification, which I think links to Max Weber's assertion of people's health behaviors, right? Their choices. Choices matter, right? Okay, well, also in the intro to sociology class was Emil Durkheim. It's a little different from Weber, where Durkheim moved away from lifestyle solely and said there was something around the social organization. People live in a relational, aspect. So, some people got the information later than others, or they live closer to the resource like the river or fertile ground. And that could be why they lived a different life. But it was something around resources that was really important. And here there's some data we've heard about Amy Kynes. Brian talked about Amy Kynes' research, and also Al Hazzouri found that those that were higher SES in this particular study stayed dementia-free the longest. So those that had the highest education and occupation, income, were able to. So something about resources, right? Something about having access to maybe quality healthcare. We agree that's a fundamental factor, but something other than decisions and behavior that's important for dementia. And then at Morehouse, we really couldn't talk about sociology without mentioning Dr. W.E.B. Du Bois, first African-American man to earn a PhD from Harvard. He did so in sociology. And his research was really around not only SES and social factors, but the impact of race and ethnicity in the United States, right? Something in addition to SES that's very, very important from Dr. Du Bois' early research. He also was a graduate of an HBCU, Fisk University in Tennessee. And so, when we think about some older data, but heart disease death rates from 93 to 2001, as education increases, the Black-white ratio increases. It's supposed to go the other way, right? So as people become, the race effect should disappear when people have the same amount of education. But in this, older data, not much has changed since this time. The Black-white ratio is actually increasing, right? So that says that there's something either wrong with the education measure, which could be, or there's some factors around the stress of acquiring this education or living a life in a higher SES, and the expectations of that return and the investment could be tough, right? And so we got to understand the lived experience of African Americans and Asian American Pacific Islanders, Native Americans in this country, because race and ethnicity are very important from a stress coping perspective, which leads to this special report that I thought was just so impactful. If getting a proper diagnosis at a timely manner, quality healthcare is so important. Well, we found that more than 1/3 of Black Americans and nearly a 1/5 of Hispanic and Asian Americans perceived that discrimination would be a barrier to receiving Alzheimer's care, right? So if your getting a diagnosis is so important, but if you feel like you'd be treated unfairly because of your race, color, or ethnicity, you're less likely to go, right? You're less likely to go and and implement that help-seeking behavior, which is also important to slow the decline. And then also, in this report, half of Black Americans report actually experiencing healthcare discrimination, at least 1/3 of Native, Asian, Hispanic Americans as well. So discrimination in the healthcare system is something that we have to pay very close attention to. Also, nearly 2/3 of Black Americans believe that medical research, all the stuff that we've been talking for the last 2 days, is biased against people of color, a view shared by substantial numbers of Asian, Native, and Hispanic Americans as well, right? And so, as we develop findings and we publish them in our journals, some of us take that and, compile that and go into communities. Not many of the people who need the information the most believes that it would actually be useful for them. That's something to pay very close attention to. And only half of Black Americans trust that a future cure for Alzheimer's will be shared equally, regardless of race, color, or ethnicity. And we see that now with Aduhelm, being approved by FDA, and CMS is considering how people can access it. And I certainly believe that everyone should have the ability to talk about being able to use Aduhelm with their families and healthcare team. Everybody should have access to the treatment who can use it, right? Really important. So that is a health equity pose, right? Well, another, I think, fundamental factor in understanding these disparities is being sure that we are including the people who are most likely to have Alzheimer's in the research. I mean, this isn't high-level science. This is just, I think, just fundamental, like, getting people treatment, high-quality treatment where they're treated fairly, they feel like they belong, and then including, these individuals into the research is so important. And unfortunately, hate to report, less than 5% of trial participants are African-American, Hispanic, Asian American, Pacific Islander, or American Indian, Alaska Native. Put another way, 95% of participants are white. And that, that may be an important reason, why there's a focus on certain types of dementia, or specifically AD as we know it. But we've got to do more with including these underrepresented populations into the research so that we can further understand why these disparities exist. It's just critical and so important. I told you the Alzheimer's Association, advocates for policy change and resources. We drafted and we are leading advocacy for the Equity in Neuroscience and Clinical Trials Enact. This will authorize $60 million per year for those Alzheimer's disease research centers around the country to do more with what a colleague of mine, Dr. Lewis Medina, had told me, inclusion science. And that is evaluating strategies for recruiting and including underrepresented populations into this research, right? So it's not a one size fits all. Not every underrepresented population or community is thinking about the Tuskegee syphilis study. Many probably are, right? Some are not able to participate because of transportation or the time of day, right? So the Enact Act will provide resources to those centers so that they can understand that from a local perspective. So we're hoping that Congress will approve that. This is what all the stuff I just said, but also thinking about participation burden, providing incentives for locating Alzheimer's clinical trials in areas with high concentrations of underrepresented populations, taking a trial to the community, to the African-American community, working with historically Black colleges and universities, HBCUs, or tribal colleges and universities, Hispanic serving institutions. These people aren't hard to reach. They're at the institution right up the street. And if you're able to develop partnerships with those institutions, you have access to participation, but it has to be done in the right way. And we'll talk about that in just a second. So, at this point, from a DEI perspective, the Alzheimer's Association certainly advocates for multi-level health disparities research. We've been talking about that all day. The framework really points to those determinants in the environment and that are sociocultural. So no new, that's not new news here. Increased diversity in health systems and health-related institutions. Dr. Fields, Noel Fields talked specifically about this. People are more likely to seek help and to stay in clinical trials, or to certainly feel like they belong in the health system when they see people that represent their circumstance, represent their community. So more diversity, and again, there are institutions that have been around since the early 1900s, late 1800s, that have trained African Americans and Hispanic, Latinos, Native Americans for many, many years, finding ways to partner with those institutions, building pipelines so that they can commit their careers into dementia care. Enhancing cultural competence, and that's for all people. You know, all providers, all clinicians, all engagement specialists should have some competence in dealing with various cultures, and maybe not just competence, but humility, right? Being able to listen and to certainly provide high quality care from a caring perspective, right? So competence and humility. And then we're taking our chapters. We've got over 70 chapters around the country. And education and awareness is important, very important. Knowing when to seek dementia care, knowing the 10 warning signs, knowing the difference between Alzheimer's and vascular dementia, just having a certain awareness of Alzheimer's. Then we'd like to do that with organizations that are trusted in these communities. So we're really focused on participatory engagement here. And so just defining these important terms, diversity certainly is identifying who's present, who's most at risk, who's underrepresented, right? And so I feel like we have done that for many years. We know who's suffering the disparities here and who's not a part of the clinical trials, right? We have to do more with intentional inclusion of various perspectives of risk, inclusion of people, so that we can pursue equity, which is a little different from equality. Equality is everyone gets the same invitation. Everyone gets the same way of thinking about risk. Equity means that we're taking the extra step to understand what it means to invite people where they feel like they belong, or considering their perspective to risk so that we can intervene in ways that are tailored and most appropriate. So when I hear terms like diverse communities, I'm like, what is that? Because diverse community kind of means, othering. It's an othering perspective for me. Call people what they are: disproportionately affected, underrepresented, underserved. That's what they are, right? So really important to know terms as we are kind of moving through what we want to do to act, right, to address these very important disparities. We're using the tenets of community-based participatory research, which creates partnerships with community members themselves, the people we'd like to serve, organizational representatives from these institutions, and researchers, so that we can share our resources. We've got wonderful resources in our chapters around Alzheimer's and dementia. Share these resources in a way that are culturally appropriate, and people can take advantage of them because they see themselves in the resources. It's really important. This has been published in the literature. Dr. Barbara Israel, School of Public Health, University of Michigan, created this model and has tested it in various health outcomes. But working in communities with organizations to either recruit them into interventions, to invite them to participate in clinical trials, so critical and important, right? And to do that, you have to build trust, right? So, you don't just call an HBCU and say, let's work together. It's an engagement process where, you gain mutual respect, shared power, right? In this case, the association can't go in and take over, and say, we're the big time Alzheimer's Association. You have to share the power, share knowledge about Alzheimer's and dementia, where the other organization shares knowledge about how to engage with community members. So really important. So engage, in elevating the trust is a process, and that's part of the established principles for CBPR. Here are just a bevy of our national partners to date. We are working there with, if you see there, the Thurgood Marshall College Fund, They advocate for many of the historically Black colleges and universities in this country. Their Omega Psi Phi fraternity, my fraternity of African-American men all around the chapters all around the country, the AME, the African Methodist Episcopal Church. Dr. Fields talked about a model, and we've got to work with Dr. Fields. I love her model on engaging faith-based organizations. So we have these partners, and we're looking to align their local chapters, their local entities with our chapters so that we can provide our resources in a way that can be helpful. You see here also Ventanilla de Salud is one of our partners. It's a program of the government of Mexico that has 50 Mexican consulates around the country, right? And so if we can align our chapters with their consulates, we can provide our resources to Hispanic Latino communities in ways that can be quite helpful. They have an average of 1.5 million people that they serve annually. So this could really increase the opportunity for us to get that information out. Our goals are to do what I just described, train consulate staff to go out and talk about Alzheimer's disease and Alzheimer's resources. And then again, align our chapters so that we can be more proactive in the ways that we provide our resources. Here's a graph. This is kind of how we monitor this around the country. So there in the red are the consulate locations. In the teal there is where we've been able to work with those locations in local communities to provide information, right, in ways that are translated into Spanish and sometimes training their staff to provide the information, which is so critical and important. Information around the 10 warning signs and the ways or referrals to dementia care specialists to get high quality care. All that's so important. So actually doing something about the disparities, I think, is really, really, really important here. So I know I have a few minutes here, but if we develop a treatment or intervention, education campaign, if we do something by 2025 that delays the onset of Alzheimer's by just 5 years, 5.7 million people expected to develop Alzheimer's in 2050 would not. That's a tremendous opportunity for us at the association and our reach into communities. And so our focus on health equity is when everybody has the opportunity to be in that number, to be in that 5.7 million number, and no one is excluded because of their SES or their socially determined circumstances in the way that Dr. W.E.B. Du Bois mentioned in his view of race, ethnicity, and class in the United States. And so health inequities are reflected in length of life or disease rates, death, and certainly access to treatment. And I'd like for us to really think about that in terms of aducanumab and Aduhelm as CMS thinks about whether and how they will cover that for people. I think people should have access to this important treatment, right? And so what are we trying to accomplish here? Really thinking about those factors in the environment, air pollution, where people live. This has come up so many times in the talks over the last 2 days, where people live and how that links with sociocultural factors like perceptions of discrimination in the healthcare system, how people cope with these circumstances. Like, so these behavioral factors that are so important. And when I think about cardiovascular risk, certainly there's the lifestyle factors that someone like Max Weber, the philosopher Max Weber might point to, but they're all determined by a context of having resources, and being able to sustain a healthy lifestyle is determined by many of these sociocultural factors. And so the question is, are there unique pathways to dementia risk? We've been talking about that, but also care and support, right? How do we provide care and support that is, as Dr. Fields mentioned, that is uniquely tailored to the people that we can serve, and quite frankly, the people that need us most, because they're the ones that are experiencing the disparities, right? And so in summary, just again, we're advocating here for multi-level research, more inclusion, representation in health systems and health-related institutions, enhancing cultural competence, and doing things that at a state level, advocating for policy change, standards and providing care with cultural competence and humility, and then participatory engagement and working with those national organizations and local community-based organizations so that we can provide our resources in a way that can be effective. So thank you.
Okay, thank you. Thank you, Dr. Hill, for this very informative presentation.